Well, hello, it's the end of September 2025. Delighted to just come and give you a quick and dirty primer on menopause hormone therapy. If you are listening to this on replay, especially if you're listening to this a year from now, I have no doubt that I will have more information. Information is always evolving, new options are available, but as it stands right now, here's our quick and dirty primer. I'm Kara Pepper. I'm an internist in Atlanta, do a ton of menopause care as well as other diseases that I take care of. Reminder that I am a doctor, not your doctor. Please talk to your team about any questions you have about this. So a reminder from last week, just about the language that we're using around menopause. So we often think that like you start your period, more or less around the age of 11. You get a period more or less every month, and then all of a sudden the lights turn off, boom, you're in menopause. And then after that, you're in post-menopause. But that language is not exactly correct, nor does it capture the full lived experience of people who are living through it, both the person with the uterus and their support team around that. So this terminology of perimenopause means leading up to the time where your periods end, and certainly the period after. We say that you're in menopause when it's been 1 year since your last period. And we'll talk about that language before that, but we know that for white women, approximately 6 years prior to when their periods stop, they start having perimenopausal symptoms in the pre-menopause timeframe. And then for women of color, particularly Black women, up to 10 years prior to that. So if the average age for menopause is between the ages of 45 and 55, it's not unreasonable that women would be having symptoms as early as their 30s. There's so-called, quote, natural menopause, meaning your body does its thing, your ovaries stop working, and eventually you stop ovulating and getting a cycle, quote, natural menopause. Surgical menopause is when you have your uterus surgically removed or have a procedure like an ablation, which stops your periods. So your ovaries are still behaving and making hormones and cycling, but you're not bleeding anymore. So that's surgical menopause. And then so-called chemical menopause would be in the situations of you've had some sort of toxin to your ovaries, like chemotherapy, your ovaries shut down, and therefore you're in menopause. So when we talk about menopause hormone therapy, which is the topic for today, generally speaking, there are three main hormone therapies. There are many other medications that are used to treat menopausal symptoms, but today I'm specifically just talking about the hormones. Estrogen, progesterone, and testosterone are the three big categories. When we talk about the estrogen that your body naturally makes, it's estradiol or estriol. The di refers to two, and the tri refers to three. So that's the way that the hormones are modulated. But in any case, estradiol is the most common form of prescription estrogen that we prescribe. Progesterone, or a version called micronized progesterone, which is also available on the market, is exactly what your body naturally makes. And then testosterone is good old-fashioned testosterone. So this terminology, bioidentical hormone therapy, is frankly just a marketing term. You don't need to pay an arm and a leg for it. You don't need to go to a special pharmacy. You can, but you can get FDA-approved, affordable bioidentical hormone therapy from your local drugstore. Bioidentical simply means what your body naturally makes. And so not all hormones and the ways in which we deliver them are created equal. They have varying different risks, price points, and accessibility. So we'll talk a little bit about that today. So estradiol. There are many ways that you can get estradiol into your body, but when we take it by mouth, it passes through our gut, gets metabolized by our liver, and then secreted into the bloodstream. And so as it passes through the liver, it increases these clotting proteins. And so the black box warning around estradiol that it can increase risk of clotting is warranted, particularly with oral estrogens. And we'll talk about ways to mitigate that. Often it is by bypassing the gut entirely, either through your skin or through the vaginal canal. So there's other forms of estrogen. I'll show you pictures. And then our second rule with estrogen is that if you have a uterus and you're using systemic estrogen, you need to protect your uterus from endometrial cancer. Unopposed estrogen used by itself, will cause the endometrial lining to develop. And if we don't have progesterone to settle that down, then the risk of endometrial cancer is higher. So you always need some progesterone to prevent endometrial cancer. We'll talk about how you do that in a minute. There's a lot of different formulations of estrogen. The ones that are FDA approved are over here. So like I mentioned, oral estrogen, good old-fashioned stuff. You can get it at your local pharmacy. It's about $4 a month, super cheap, one pill a day, varying doses. because of the clotting risk, what you most commonly see menopause practitioners prescribing is a transdermal modality. So there is a patch that you can use on your skin. This is the clear one that is twice weekly dosing. So you put it on more or less Sunday and Wednesday, and you're good to go. There is a once weekly dosing version. It is much bigger than this. It's probably like the size of a lacrosse ball, and it is pale pink. And I am a pale pink person, and it barely matches my skin color. So in other words, it's very noticeable, and I don't think it's appropriate for many patients. And it doesn't stick as well. So this twice weekly version is the one that most people will use. You can also use an estradiol gel. It's like comes in these little packets which you can rub on your skin, and it can get absorbed through the skin. They've actually looked at application process for transdermal estrogen, specifically this one here, estrogen that we insert into our vaginal canal. And does that get absorbed by particularly sexual partners? And the answer, in short, is not in a clinically meaningful way. For people who have penis and vagina sex, that if they come in contact with this cream, it may minimally increase the absorption of estrogen for the partner, but not enough to put it out of range. So you don't have to worry as much as we used to think about people coming in contact with this. But the transdermal patch, or this one, we use every day. So, excuse me, this is twice a week. This one you use every single day. And then this vaginal estrogen cream, which is amazing for improving circulation to the vaginal tissues, improving the microbiome, the bacteria that live in the vaginal canal, and improving bladder symptoms, because we have estrogen receptors all the way up into the bladder. This is also used twice a week. So, and then lastly, I have kind of hiding in the corner over here, estrogen injectable form. I would be hard pressed to think of more than one or two patients in my practice who use this. It's an injection once a week. It's more expensive, and there's much better like what we call pharmacodynamics with some of these other ones. You have more smooth dosing of estrogen. So this is like way down on the list, but I put it there as, for completeness sake. On the right side of your screen, you'll see this injectable pellet. If you've ever heard of people using pellet therapy, this is what they're talking about. Basically, every 3 months, this little pellet gets injected under the skin. It's not FDA approved. It's not covered by insurance. It is the most expensive out of all of these options. And I personally don't love it because you can't always guarantee the standard dosing of estrogen at a consistent level. You know, you'll get high peaks and then it wears off over time. So I do have a handful of patients who use this, but it is not my favorite. There is a role if all of these other options are not accessible or they're not working, but you may hear about people using pellet therapy, and that's what that is. So I look at estrogen as like an a la carte menu. What is your personal risk? What are we trying to treat? Is it pelvic symptoms? Is it systemic symptoms? What is covered by your insurance? And what's your personal preference? I did not actually, I forgot to put it on the screen. There are other forms of vaginal estrogen besides just the cream. There is a tablet that you can insert into the vaginal canal, and there's also an ovule, kind of looks like a gel cap. So for folks, for example, who don't like the mess of vaginal estrogen, you can use a tablet. Some people like the vaginal estrogen cream because you can literally rub it into the vaginal canal and up towards the bladder, so it gives you better coverage. So as it turns out, I have to talk to my patients, figure out what works for them, what symptoms I'm treating, and then we choose from this kind of menu of options. So that's the quick and dirty on estrogen. Who should not use estrogen? Again, if you have an active ongoing estrogen receptor positive cancer, specifically like breast cancer, endometrial cancer, ovarian cancer, I put in there again about our endometrial cancer risk. If you have a uterus and you're using unopposed estrogen, you need progesterone. If you have a recent blood clot, especially if you are not anticoagulated, that would be a reason not to use it. If you're high risk for stroke or coronary disease and have an increased risk of clotting, people would, weigh risks and benefits around that. And if you have active liver disease, so those folks should not be using estrogen now. Okay. This is a graph from last week, a reminder that when they started using estrogen a long time ago, 80 years ago, people felt great. People were prescribing it more and more, but then they found that there was this endometrial cancer risk. So people stopped prescribing it. But then once we started adding progesterone and realized the risk was mitigated, you started seeing people use a lot more progesterone. So let's talk about that. There are many different ways to get progesterone in, just like progesterone. The easiest and cheapest way is progesterone capsule, typically taken at night. I think about this medication with a rule of threes. So like a third of women will tell me it is the best sleep I've ever gotten in my entire life. I love this medication. It's great. About a third of people can't tell the difference. And about a third of people may say, I'm having increased breast tenderness. I feel like I'm hanging on to a little bit more fluid. And it's not my favorite. So I have a generally love-hate relationship with this medication, but it is a necessary thing. So for folks who don't tolerate it, we have other options. One option would be to use an IUD. So don't worry about systemic treatment at all. You don't have to deal with those symptoms. You can literally put the progesterone right into the uterus, leave this bad boy in there for, up to 8 years, and it will directly protect the endometrial lining. I love this option because then it gives people all kinds of different options with their other hormone therapy. So set it and forget it. There's also the Nexplanon, or another subcutaneous version of progesterone. This is medically inserted underneath the skin and can stay there for 3 years. That will also protect the uterus. You may hear about people using a progesterone cream. It's good for symptoms, but it's insufficient for protecting the endometrial lining. So that is not one I recommend if you're using estrogen with it. And then testosterone. So testosterone has loads of benefits. Not, of course, we think of testosterone as the libido drug, but there's emerging evidence looking at cognition, looking at muscle mass, looking at bone density. In general, people, when I put them on testosterone, they'll just say, I just feel well. I feel more like myself. I feel like I have this vitality that I didn't have before. And so there is no current FDA-approved testosterone for women, unfortunately. Even though women make, if you measure molecule by molecule, more testosterone than a man does, it's a whole nother conversation. So what do we do if we don't have this FDA-approved medicine? Often you'll find that people lean in towards compounded medications more frequently than they do the estrogen and progesterone. So here's some examples. So there is FDA-approved testosterone, only currently FDA-approved for men. So it comes as an injection, which is once a week or once every 2 weeks, depending on how someone doses it, or a gel. The gel comes in these packets, and the dose in one packet is 1 packet per day for men, but in menopausal women, it's 1/10 of a packet. So sometimes you see people like squirt out a pea-sized amount and rub it on their skin. They'll sometimes use a syringe and squirt amount on their skin. My personal thought is like, this is just kind of messy and annoying to deal with. But if your insurance will pay for it, it's an awesome option if you can get your insurance to pay for it. The injection, although it's longer lasting, you'll have a high level that weans off over time. So it's less consistent levels throughout the week, and you have to inject it. So we see this used more commonly in men and less commonly in women, but it's technically an option. The one that you most commonly see women use is this compounded testosterone cream. It comes from compounding pharmacies. It looks like a deodorant roll. It literally, you click it just like you would with a deodorant, and it like squirts up through this little hole, and then you literally just rub it on your skin. You can rub it on your arm. Many people will rub it on their abdomen or on their leg. Typically, people do it when they get out of the shower with the rest of their lotion. So it's an easy, measured way to get that dosing of testosterone. You may also hear about people using oral testosterone, a troche, which is kind of like a lozenge, like a gummy lozenge. The problem I find with this, again, is inconsistency of dosing. Yes, you can use it by mouth, but if you swallow it, it doesn't get absorbed through your GI tract. It literally needs to be absorbed through the lining of your mouth. So it's a little finicky in that you have to put it under your tongue or in your cheek and just let it dissolve there and absorb. So I don't find that people get the most consistent levels, but an oral option is an option. And then lastly, again, the pellets. Again, these are the most expensive. They are also not FDA approved, and they have varying levels of testosterone, and this has to be done by a doctor. So probably the most common you'll see is if we can get testosterone covered, we'll use the packet. Otherwise, many people lean in towards the gel. So I'll answer any questions that y'all may have after this, but in short, when I look at this menu of options, I look at it just like that. It is a menu. You have to figure out what the person in front of you is trying to treat. How do we get them feeling better? What are their concerns? What are their preferences? What is their insurance limitations? And then we have this menu of options to choose from. pointers about that. One, I don't like starting all of these hormones at the same time, because if someone is going to have side effects, you want to know which medication is causing it. So it's okay to start them in a staggered fashion, even one medicine per month if you want to do it that way. Some people will spread it out, one new medication per week. But typically I'll start people on estrogen first and then let their body accommodate. They usually figure out pretty quickly if the medicine is working or not, and then add in the progesterone later on. And then after that, we move on towards the testosterone. That's my personal preference. There's a question, what's the best practice on when to start HRT in the perimenopausal cycle? It's complicated. So, so the good news about when you're still getting a cycle is that you are flushing out your endometrial lining. So the issue about endometrial cancer is not zero, but it's much, much lower. So if you've seen any of the my lecture from last week, you'll know that during that perimenopausal time period, our hormone levels are actually more wildly fluctuating than they are after you get into menopause or prior in your earlier years. And so sometimes you'll see people put a low dose estrogen in there. So instead of having this really big swing throughout the week, a low dose of estrogen kind of puts like a floor there. So it just has less kind of chaotic flows. So if you're having symptoms, particularly like pelvic symptoms, like urinary frequency, dryness with intercourse, etc., you can start estrogen patch. You will sometimes see people using estrogen patches alone if they're still regularly menstruating. But from a legal standpoint, often doctors are worried we don't want to cause endometrial cancer, so they'll cycle the progesterone like 7 to 10 days a month, or you can even take it every day of the month. So I like the estrogen initially if you're having, like I mentioned, pelvic symptoms, hot flashes, word finding difficulty, brain fog, those types of things. In addition, or instead of, because we know that testosterone already starts to wane in the late 30s, you can take testosterone alone in that window of time and wait until you develop estrogen related symptoms, the vasomotor symptoms later on. There is no right way to do this. Again, I'll keep coming back to like, you have to, you meaning physicians, we need to talk to our patients and figure out what we're trying to treat and figure out what the individual's risks are. But if someone's having symptoms, I would rather just treat the underlying pathophysiology, which is treating this hormonal fluctuation that's there. And I do have patients that I'll treat and then they'll be like, I don't feel any difference. I'm like, okay, great. We don't need to stay on this medication for now. We can revisit this topic a year from now. Maybe it is too early. We would have no problem putting people on birth control pills, which are much, much higher doses of synthetic estrogens and progesterones for years. Like that's never been a concern. So starting low dose hormone therapy, I have no problem doing in a trial and error format. And across the board, I had patients say, this has changed my life. And other people say, maybe I can't tell a difference yet. And we just delay it another year as your body is moving closer and closer to menopause. Other best practices. Happy to answer any questions if you had specifics about that. But I hope that helps.